So our panel this morning are Caitriona Walsh, President and Managing Director of Novartis Ireland. She studied biotechnology at NUI Galway and completed her PhD in immunology at Trinity College. Sara Burke is Associate Professor in Health Policy and Management and Director of the Centre for Health Policy and Management at the School of Medicine in Trinity College, Dublin. We're also joined this morning by Professor Rob Landers, who is President of the Irish Hospital Consultants Association, and Robert Watt is Secretary General of the Department of Health and formerly Secretary General of the Department of Public Expenditure and Reform. Please give them a warm welcome. So Rob Landers, Rob, good to see you, and I will ask you first of all if we concentrate for a few minutes on Slaintecare. Do you or your colleagues see any evidence of any of the reforms, any of the changes that Slaintecare has promised? And it's been agreed since 2017. Do you see evidence of it on a day-to-day basis?
Any real progress in the hospitals. Now, I'm speaking from a hospital perspective. So since the introduction of Slaintecare, we've seen a 49% increase in the number of patients on waiting lists. We're looking at the highest ever number of attendances in our EDs. We're looking at increasing numbers of people taking up health insurance now, which seems to go against the stream in terms of implementing universal healthcare. So we're not seeing in the hospitals a real effect of Slaintecare. There is more care being delivered in the community, but the demand on the hospitals is increasing all the time. And and Slaintecare hasn't yet delivered the increased number of hospital beds, the increased number of consultant posts that it needs to properly work. So, we're 6 or 7 years into this Slaintecare programme now. We're not really seeing it in the hospitals.
But one of the core elements was taking private healthcare out of the public hospitals. Yep. And that's where we get to with the public-only consultants. Now, am I right in thinking that the implementation date for the starting of that contract is today?
No, Robert, beside me, we agreed to push that out for a short time period to give us a chance for a consultation process with the consultants right through the IHCA and the Irish Medical Organisation. So we're probably looking at it in about a month or 6 weeks' time for that.
And how do you see that going?
It'll be a tricky implementation. The new consultant contract was hard negotiated on both sides. It's, from our perspective, it's not a perfect contract. From the Department of Health's perspective, it's not perfect, but there's a decent compromise in there. We're still going through a little clarification process with the department on certain aspects of it, and it'll go to implementation. The take-up rate, we're unsure what that will be. I'd like to be in a position to say it'll be very high. I'm not so sure. It'll suit some consultants, it won't suit others.
But what part will that play in helping to deliver that central core of Slaintecare's policy?
It'll play some role. When you look at the activity in our public hospitals at the moment, only about 4% of the activity in the acute hospitals is for private elective care. So it's going to take that out, but it's not going to deliver a huge increase in capacity that we need. So it'll remove that stream from the public system, shove it onto the private system, which is already at capacity, but it won't free up a huge amount of capacity within the public hospital system.
Sara, how would you assess progress to date on Slaintecare implementation?
Hard to do in a soundbite, Audrey. My overall assessment would be it's happening. This time, 6 years ago, I was working with the Oireachtas committee that produced the report, and the year after, in 2018, it was adopted by government. So I think if you look at all the policies and even the service plans, although I think we've yet to have a HSE service plan for this year, but if you look at all the detail of HSE and Department of Health, Slaintecare is driving the policy intent. So it is there at a policy level. I think in terms of at an implementation level, which is what you've been talking to Rob about, it's been slow, and it's been slower in some areas more so than others. You could totally say we've lived through a pandemic, and of course there was delays, but also the pandemic has accelerated aspects of Slaintecare. So we have seen bigger investment in the health system, investment at the level that was laid out in the original report needed. We have seen a significant increase in workforce, despite the challenges Ronan outlined of the global workforce demand. There are 15,000 more staff in the HSE now than there were this time 3 years ago. But there are still challenges in that we haven't done. The removal of private practice was never about increasing huge amounts of capacity in the system. It was about providing equitable access or universal access so that everybody got care on the basis of need, not ability to pay. But it's just one cog in a very complicated machine, and many more of those cogs need to move at the same time. So a big one that needs to move is this investment in the community. And yes, we are seeing that if you look at where the HSE staff, and yet recent analysis done by Porg Fleming, a colleague of mine and team in the Centre for Health Policy, would show, yeah, we've many more staff in the system. We're actually still putting more staff into the hospitals rather than the community. And to deliver on Slaintecare, to take the pressure off hospitals, to provide better access to care, we need to do way more. So we're beginning to do that investment in the community, but we need to do much more of it. Just another point I think is important that happened during COVID was that everything was universal, free at the point of delivery. And all new services, a lot of the women's health services being championed by the Minister, are similar. So I think that's showing a shift in how we are delivering care. But the big challenge now is how we do that for the whole body of care, not just the new services that are coming in. And to do that, we require the leadership. And it's not just ministerial leadership, but we need the Taoiseach and the Taoiseach and the Minister for Finance behind it. We need clarity around governance, and I'm a bit confused in relation to the governance since the resignations of Slaintecare. And I know Robert and the head of the HSE manage this Slaintecare programme board, but who's ultimately responsible for driving that reform? And then I think there's a key issue in relation to engagement of staff and engagement of individuals and communities, and that issue of trust. And again, a colleague of mine, Sara Parker, has led on a piece of research around the really fantastic, agile, innovative change that happened in the system during COVID that will help deliver Slaintecare reform. And people on the front line saying to us, we were trusted during COVID. We were given that freedom to innovate, to change. And now that we've moved out of the crisis, it's like that trust has been taken away from us again. So I think trust and empowering communities and people who use services and people on the front line is absolutely central to delivering, and I don't think we've got that right yet.
Robert Watt. Robert, you're welcome. As Secretary General of the Department of Health, you are the co-chair now of the Slaintecare Implementation Board. How would you say it is progressing at the moment?
Well, good morning, Audrey. Good morning, everybody. It's great to be here. So I think just to clarify in terms of the governance here, as ever, in our democratic system, the person who is ultimately responsible for delivering healthcare and delivering reform is Minister Donnelly, colleagues of the government. At the minister level, myself and Steve Mulvaney, the acting CEO of the HCA, are responsible for the delivery. We've established a delivery board with colleagues from both the Department of Health and the HCA who are responsible for individually driving the larger projects within Slaintecare. There's about 8, 9, 10 of those projects, and significant progress has been made on those. In terms of how I would characterise the change, I would of course say that there's fantastic change taking place, Audrey, of course I would. Most people in this room would also agree with that because that's their lived experience. But of course we can do more, and that's the challenge. How can we do more? So how can we ensure that we can access the resources? How can we reform working ways, pathways? Ronan talked about the whole data and digital agenda. How can we ensure that we have the correct leadership, skills, motivation and resourcing to drive that foundational change? So the challenge really for us is to accept that we have this plan and people are committed to this plan, and what do we need to do then to drive it? And change can be difficult. Change can be difficult within an organisation the size of the HSE and with the responsibilities of the Department of Health. Rob and I, for example, in relation to the consultant contract, spent 16 months negotiating. The Department of Health didn't spend its time negotiating with its own contract. We were very happy with the first draft we produced 16 months ago. But we had to negotiate with the people who were delivering, and Rob is a very nice fella sitting here, but God, he was a bit difficult at times during these talks now, I must say. It was with a few touchy moments, hours and hours and hours fighting about semicolons and commas and obscure points in a contract that goes on and on and on. But we got there. So the change challenge, we have to deal with employees within the system. We have to deal with individuals who deliver services on our behalf who aren't employees of the system. So extending, for example, free universal care within the GP system. The people who deliver that are not employees of the health system. They're self-employed business people called GPs who work in general practice across our communities. We want to extend that. We would do it in the morning, but of course we have to negotiate and we have to reach people who aren't our employees. So there's richness and complexity, a function of how our system has evolved over decades and decades. Disentangling that in the context of reform and change is challenging. That's what we're about. I think and I think Sara has acknowledged significant progress. I think that's accepted, but the challenge for us is how do we accelerate that now on behalf of citizens, and particularly those citizens who aren't accessing the care they deserve. And these are people in the main who have to suffer the consequences of queuing, people who are not insured, who don't have medical insurance, and they have to suffer the consequences of queuing. And for us, that is the main focus. How can we drive the change and reform to increase the supply and the activity to ensure that people don't have to wait as long as they have to for care? But amongst all this challenge, and Roland touched upon it, the life expectancy in Ireland, the health outcomes are very positive. The challenge really is how do we drive access for those people who are currently do not get the service they deserve.
Caitriona, let me bring you in. You're our President and Managing Director of Novartis Ireland. You were telling me you're just back in Ireland after 9 years. From your experience in other countries, what are your thoughts on the Irish healthcare system?
Great, thank you so much, and lovely to be here. So coming back after 9 years away, I guess I felt that lots had changed, but also maybe nothing had changed at all. So I'm probably in between, I think, in terms of my views on where we're at with Slaintecare. But I think we need to really welcome it. And I think the political will is there, and it's really clear that it's there. So I think that's really welcome. What's really important is this focus to move things into the community. And also, I think the focus on chronic diseases. You know, Ronan clearly illustrated we've got this tsunami coming of, you know, over 65s doubling in the next 20 years or so. So we need to really be prepared and move as much as we can out of the hospital setting. It's slower than we want. And actually, people are at the heart of it. And what we need to do is actually completely transform how we operate our care. It has to move to patient-initiated follow-up. That is the way we're going to have to do it, rather than just managing people with the current status quo of a yearly follow-up or a 6-monthly follow-up. So that does need to change. It's very clear as well, we need some of the fundamental building blocks, I think, and that's where we need to accelerate. So if we think about the electronic health records that many countries have in place already, that in Ireland we're still building on that. If I was to think about Brian and reframe it, we could look at that as an opportunity, because actually we don't have a fragmented system of electronic health records that other countries have. So actually let's look at that as an opportunity in Ireland to say, let's do this right now. But actually we have to get that right, because if we get those building blocks in place, that allows us to interrogate our data in the right way to completely transform care. It's going to enable us to do better research. And all of that is going to ultimately bring in more qualified doctors into the space who want to be part of cutting edge research and innovation, and it's going to enable better patient care.
Rob, I'm just wondering, who does the Irish healthcare system work for best? Because I'm thinking of the patient, and I'm thinking of the patient who had to attend the EDs over Christmas the last number of weeks. I'm thinking of the children, the young adults and their families who were being treated under CAMS, the adult young children and young adult mental health services. Who do you think it works for best?
I think, Audrey, when you look at a high level of who it's working for, the difficulty is in the point of access. And people often say once you access our hospital care, that the standard of care within the hospital system is really very high, and it's world class in a lot of aspects. And we have cutting edge technologies available in all our acute hospitals. And if you look at our survival rates and our complication rates in cancer care, for example, they're comparable on a world stage. So once you get access into the system and the professionals within that system, right across the board, from the hospital cleaner cleaning the room right up to somebody performing invasive neurosurgery, the standards of care provided are excellent. So the difficulty is in the access. Who is it not serving? It's not serving the people lying on the trolleys. It's not serving the young adults who need mental health services. They can't get access into the system. So once you get in, it's working, whether you're a public patient or a private patient, but the problem is getting in.
Sara, what's your view on that?
I'm not sure it really works well for anyone right now. I think people can experience good quality care, but we actually don't have the data to show us that across the system. And I think if we think of Brian's opening keynote in that issue of time, many people in Ireland have to wait months or years to access care, to get into care, and then when they're in the system, they have to wait hours or days to get essential tests. People still, for example, cancer patients still have to go through emergency departments to access acute medical care at the moment. That, in my opinion, that's barbaric, that we haven't provided alternative routes into the acute hospital system for people who really need that care. And also, I think the really critical issue at the moment is workforce. And it really doesn't work for most people in the workforce. We have a very tired, burnt workforce who feel fundamentally undervalued. And that's why we need the reform. We need the reform so that we have an empowered, valued workforce who are enabled to provide much better quality of care. And that's not to say that that doesn't work well in some places for some people, but certainly my experience of trying to access care, and I know the system pretty well, and I can game it for any bit it needs to be gamed, is that it's survival of the fittest. That you know, I say this about my 86-year-old mother. The only thing integrated about her care is that I am coordinating it. And that is the experience of people trying to get in the system. And the whole point of the reform is that there's easier routes into the system, and then people are supported the whole way through it. And that's why we need that reform.
Robert, what do you say to that?
So we need to reform, and I think the point about Sarah's last point in relation to integrated care for older people is absolutely critical. There's been significant investment now in community care, the various teams that are being put in place. We have almost 3,000 people now employed, and that's growing all the time. And we need to do much more, and particularly when it comes to older citizens, frail citizens with many different conditions, and to change the model of care so that it's closer to the community, closer where they live, keep them out of hospital. So we all know that, and we're pushing ahead. And our colleagues at the IHCA, I think, are doing a great job in that aspect of our home. I think it's very, very significant. But I'm going to disagree with Sarah, if we're allowed to disagree with each other in these days. It's not fair to say that the system in the main provides fantastic care for most people most of the time. I can go through the stats. There are millions of interventions every year, whether it's consultations people have with Rob's colleagues in hospitals, or I think the 26, 27 million consultations with GPs every year. People's engagement with the system in terms of procedures. Like last year, we took over 1 million people off waiting lists. There were 300,000 procedures undertaken in the public system. That's even to exclude discussing the private role. There's 2,000 beds and significant procedure in the private. So most people, most of the time, have actually a good experience. And as Rob's point, when they access the system, they go on fair. But of course, there are gaps, and people are waiting too long for certain procedures, and we have periodic issues around trolleys, and we had it at the beginning of this year, which is unacceptable. And people mentioned CAMs again, clinical failures, which are unacceptable. But I think we need to have a debate which is based on a realistic assessment of how good the system is, but also be honest about its failings. And on that basis, we can move forward. And I think there is a broad consensus about the need for us to invest more in capacity to change the way we work. We need to end the practice of private consultants giving preferential treatment to private patients in public hospitals. I think that needs to end, and I think that will end. We will have a new consultant contract this month. Rob is engaging in his consultation. When they're concluded, we will publish a contract, and I hope many consultants will accept this contract and many new consultants will come on board. So there's a pathway there. It's about making the system better each year. That's what it's about. Perfection is not possible in a public health system in Ireland or anywhere else. Our task is to make it better, and that's what we're doing, and that's what we're focused on. But I think the basis, the start of the debate needs to be an understanding of what works in the system, thanks to the brilliance of the people in the system, and what doesn't work. And we need to be honest about both of those aspects.
Sarah?
Just to clarify, the question was, who does it work for best, Robert? And I don't think it works for anyone best. So we can disagree on that.
We'll be having a linguistic debate about what those terms actually mean. So for a lot of people, they can access timely care and brilliant care, okay? Of course, for many people, they don't have those advantages. So for those people who mentioned, the system doesn't work as well as it ought to for certain members of our community. Absolutely.
Caitriona,
We probably don't disagree after all. So
you think timely access to medicine is extremely important?
Absolutely. You know, we've spoken a lot about weight and about time, and I think access to medicine is absolutely critical here. You know, if we think about trying to keep patients out of hospital, we know that innovative medicines absolutely do that. And unfortunately, you know, thinking about time and the population of Ireland having to wait for access to these innovative medicines, we rank 19th out of 29 in Europe in terms of access and speed of access to innovative medicines in Ireland. So if you think about what could we do if we could improve on that, that would absolutely speed up then patients getting these innovative medicines, keeping them out of hospital and in the community and in their homes where they deserve to be. So
and how do we do that, Caitriona?
Yeah, I think in many ways, I think there's already a lot of reform within the reimbursement system, but we need more reform. I think we need a more transparent system in terms of timelines. We also need to look at resourcing. So it's back to workforce as well. So is the reimbursement system set up to actually have the capacity there to deal with it? Because much of this is capacity and funding. Funding is always a question, always a problem. But what we're finding now is even when there is funding there, because of the capacity constraints and the delays, we can't actually even enable these medicines to come through the system. We rightly have very stringent controls on which medicines should get approved. So they have to go through a very robust health technology assessment and prove that they're cost effective before they can actually come to the market. And then on top of that, there's medicines management programs which allow for further cost containment just to make sure that people don't lose the run of themselves. So that's great and that's welcomed, but actually we need to make sure we do that in a much more timely manner to make sure that the patients of Ireland are equal to their European counterparts in terms of being able to access these innovations.
Rob, you want to come in there?
no, like what I would say to Caitriona is that if we can reduce the price of medicines more broadly, the government is committing to spending every single cent saved on new innovative medicine. So if Caitriona wants to engage with us and her sector on how we can reduce the price of medicines, we give a commitment now to invest all those savings,
Thanks
Caitriona,
so much,
in
Robert.
new medicine. You're very welcome.
And
we'll make that commitment, and the government has made that commitment. And just to say that the spending on drugs in Ireland goes up about 5-6% every year. It has doubled. What's 6 by is doubled in 10 years. The spending on drugs. There is a limit. There is a finite. But we would commit to every single wonderful, innovative drug, right? You produce. We will go and engage with you if you could reduce the price of all the other drugs, which absorb 3 billion, 3.5 billion of our budget.
So I think that that's actually one area where the industry, so the IFA body, actually does really well in terms of pricing of drugs is one of the areas of continuous reform when we look at overall health spend. So I think it accounts for about 15% of health spend. There's huge scrutiny. So every 4 years there's a renegotiation. And actually every year there's an annual alignment of prices with the European average, a downward alignment. It never goes up, it always goes down. So I think there's great mechanisms already in place. As I've already mentioned as well, the health technology assessment to make sure that everything is deemed cost effective. But that's only 15% of the overall health budget that actually has this regular scrutiny. What about the other 85? And I think in order for us to really have true reform, we have to look at the same level of scrutiny across every penny that we spend in the health service.
We'll commit to having the cheapest drugs that we can have in Ireland, okay? And then ensuring that Irish people are not 19 over 29 anymore, they're higher than that, okay? So if we can agree that we'll have the cheapest drugs of any country within the OECD, then we'll ensure that we go from 19 up to the top 10 in the next few years. That should be our goal. And maybe we should do this review every year, Caitriona, not every 4 years. But anyway, we'll...
There is an annual review every year, Robert, as I just mentioned, but thank you.
Keep sending your questions in on Slido. You're sending them in here and I'm reading them. I'm going to get to some of them now in a few minutes. Rob Landers, Professor Landers, what would a reformed healthcare system look like in your mind?
It would look, I think, vastly different from the one we have now. We need to vastly increase capacity and we need to integrate the entire system. So we're talking about, hospitals versus communities. We're talking about which have historically operated as different silos in Ireland. We're looking at regional health authorities, which talks about aligning the hospitals and communities. We don't need to align them, we need to integrate them. It's the same patient moving from the hospital into the community. And the other huge thing that would transform our Irish health service is a proper digital electronic health record. And the frustrating thing is we have little snippets of that are there. I remember in October, I got nabbed walking down the corridor in the hospital by a nurse practitioner wanting to give me the flu vaccine. I took that. She took my details on a tablet device. The following day, I was driving by the COVID-19 vaccination centre. They just had the new Spikevax vaccine. I said I'd go in and get that as well. You know, within 2 minutes walking in the door, the lady was telling me, I see you got your flu vaccine yesterday. And, you know, again, so there are elements of that are there, that can work, but we need to roll that out. So if you're thinking about your therapist in the community, your home physiotherapist looking at somebody's need, is thinking they're not happy, it's limiting the patient's mobility, you know, they should be able to go on a tablet device and see, okay, where's the next orthopedic appointment? I'd like a consultant to look at that knee. But, you know, and it's the same patient that's sitting at home that's going to move into the hospital and going to move back home again. So we need to break down those barriers right across the system, and we need to transform our ICT capacity and ability within that system. I think it would lead to huge improvements in patient care. If your general practitioner is there with a patient sitting in front of them and they need an endoscopy, you know, you should be able to log on and see what slots are available. Is that in Waterford? Is it in Clonmel? Maybe it's in the Mater in Dublin? And say, yeah, will you go to the Mater? They have a slot next week. You know, and get that endoscopy done there, get the results uploaded, the biopsy results come back, and they're all available to the patient in West Cork or in Waterford or wherever they are. So that would transform our health service, but not on its own. We need to increase that capacity and integrate it right across the system as well.
Robert, on the patient records, it is incomprehensible, I think, to many that in a first world country that we don't have such a system, and particularly in the last 2 years, given, as Rob says, we saw so much integrated healthcare working for the patient.
Yeah,
why hasn't it happened?
And we do have pockets of success, digital success, and good examples of data sharing and using new technology and platforms data. But absolutely, Audrey, it's not good enough. I think everybody accepts that within the system, and I agree with Rob in terms of the priorities. The priorities are around data and digital technology, and they are around integrated care and that journey for patients. I would also add, ultimately, a system where your insurance status does not ultimately determine your access, or that the gap between people who are insured and non-insured in terms of the health outcomes for them narrows to become almost indistinguishable. That's where we ought to be getting to. That will take many years, I know that. It will take many years for us to put in place this new consultant contract to ultimately move private out of public hospitals, to build up the private capacity, which is an important component of this radical change that we are embarking on. So I would agree on those priorities. We do, when it comes to the digital space and the data, we need more leaders within the HSE. We need reinforcements. We need people with those capacities. And this is not any way to criticise the people who are there, who are wonderful, but we need more. We need more people. It's a big change, and we need to embrace that change, and it's going to take us. But I think those reforms can make an enormous difference. Like, the system is incredibly paper-based. A lot of time spent on basic administration and technology, we all know, can transform those basic tasks. It also can reduce the many of the failings. Like, doctors, for some reason, can't write legibly. I don't know what it is. Maybe Ronan can tell us later why the training is so inept they can't write clearly, but it seems to be an issue about people in the health system not being able to write clearly. Civil service training, you're trained how to write as well as type back in the day. But again, I don't want to be flippant, but we do know there are mistakes made, unfortunately, because people are in such a hurry. And so all that technology, I think, can we need to embrace and galvanise the system. But to talk about that, that's easy. What it does mean to have the people with the skills and the capacity, to have the leadership commitment, to have the resourcing, to have the partnerships with all the different groups that are required to do that. So,
Sarah, your view on this, on the question, I suppose, that we started off with, where health policy meets health care, and back to what Brian was talking about in his opening remarks. Does the patient lose out ultimately when that health policy does not meet health care, when there is that battle between clinicians, the medical teams and politicians?
Of course, and it's the people who are sickest and most in need of that care, and that's what we saw over Christmas with the people waiting to get into emergency departments, or indeed through the CAMS crisis in terms of children and adolescents getting totally inadequate and appropriate care. So that's a failure of the system to reform. It's a failure of clinical governance. It's a failure of reform. But in terms of what the system will look like, I think for me, it won't happen. We've had so many promises of reform that it's only when it's tangible to people, when somebody can bring their child to the local primary care centre to get triaged by a nurse who says, actually, you don't need to see a GP, or you don't need to go to an urgent injury clinic or an ED, that for an older person to navigate that care through your local primary care centre, that management of chronic diseases at home, of course, all the stuff that both the Roberts have said in terms of an empowered patient, electronic patient records on your phone, but it's when we experience those tangible benefits. And I think we did experience some of those during COVID, the access to vaccinations, the being able to talk to a GP on the phone, even if you couldn't go and see them in person. They were real positive benefits to people, and they really value that. And that's only when people will realise the reform in Ireland, is when people begin to experience that. And all of us as patients or users of services become empowered, but also that has that knock-on empowering impact on the people providing care.
Robert?
Well, just to say, just because this is people who come to events like this are motivated to hear, and they're motivated to hear exchanges, and this is a group of people here. There shouldn't be any doubt, Audrey, about the commitment of senior people in politics or in the Department of Health or in the IHCA about this reform agenda. There should be no doubt by anybody in this room about the seriousness of this. And Rob and I spent a long time negotiating this new contract, and Rob can confirm, if he gets the chance, the extent to which we are absolutely committed to delivering this agenda. There should be no doubt whatsoever.
Robert, can I just make a point on that?
I was at a Dáil committee there a few months ago, which are always great occasions. And at the end of the discussion, I had the opposition congratulating us in respect of, we've concluded our initial chats, Rob, about your wonderful contract, and we'd made announcements in relation to elective hospitals and others. And for the first time, I can remember a Dáil committee, people actually saying, yes, we can now see that this reform is taking place. Now, we can always say it should be faster, and we can always pick aspects of it and say, that's not been done as much as that, or because by the nature of it, it's multifaceted. There's so many different aspects of it. And when we do all the things that we're going to do over the next 3, 4, or 5 years, when we meet again, whatever it is, people can still say, well, you haven't done enough. That's absolutely fine. But I don't think we should frame the debate that people are not committed, that the reform is not taking place. I think that's a mistake. Okay?
Yeah, and I'm not saying that. And I think it's really important for you, people like you and the Minister, as he did in his interview with Tony O'Brien before Christmas, to constantly reiterate and drive that reform, because we know it has to come from the top, and that's really welcome. And I'm probably one of the few anoraks who sits through and watches those committees, and there's a huge amount of information, and I think it's sort of the best of our democracy at work in terms of robust interaction between senior officials and our elected politicians. But there are gaps in transparency and accountability, Robert. For example, up to 2021, every 6 months there was the Slaintecare progress report published. There hasn't been any since December 2021. You haven't published any minutes of the programme board minutes since last September, or last time I looked, which was about last week, on the website. So there are issues, like if you are committed, you need to translate that so that people hear that and see that, and that requires regular publication of reports, publication of minutes. It requires delivering on that accountability and transparency.
I will check when I return back to base camp, but we publish our minutes of all our meetings. We publish numerous reports on Slaintecare.
There's been no progress report since December 2021.
Hear me out now for a second. And I attend Dáil committees on a regular basis.
You do.
Where I count.
That is true, but you have to.
So to suggest, well, on occasion I've said no, not really, you know. But on occasion I've said no, not really. But so I just don't accept. I really don't accept this notion that we're not transparent about what we're doing. Sorry, I don't accept it. I'll check what I get back.
Okay, well, the research I do, right, this is not just random thought by Sara Burke, believe it or not. Like, we do detailed research on the health system, and what we're hearing from people on the front line, and actually people quite high up the management, is that there are issues with transparency and accountability. And I think a key to the reform is improving on that and building on some of the good practice that has been in place and making up for some of the lapses perhaps there's been in the last 15, 18 months. Because if we can't see and feel that reform, it's very hard to persuade everyone in this room to try and go out and deliver on it.
You said, so you said there was no transparency, and now you said there could be more transparency. I accept we're transparent and we can do better with transparency, absolutely. Who can't?
Okay, I just want to get a final word from Caitriona, and there's a question for you, Caitriona. Given your comments on the timely access to medicine, someone wants to know, would you support non-medical prescribing for HSCPS, such as physiotherapists, as is currently happening in the NHS?
I think, and I think it's said even in Slaintecare as well, we need people prescribing to the top of their abilities. So we're people acting and working to the top of their abilities. I think the NHS has made massive progress in terms of nurse prescribers, physio prescribers, giving extra powers to pharmacists. So I think we should learn from that. I don't think it's up to me to comment. I think that will be for Robert and his team to look at that. But I certainly believe where there's a will, there's a way. And we have got amazing people working in the sector, and we should allow them and empower them to actually do the best that they can do. And my last kind of word on it is this won't work in isolation if it's just the public sector doing something or just the private sector doing something separate. We're going to need partnership. We need partnership at the very highest levels. If I'm just back from the UK post-Brexit, the UK decided, right, we're going to be winners in life science strategy and we're going to have a proper strategy here. They've done a huge partnership on population health across cardiovascular disease, something completely different. We need that same level of disruptive thinking. We have to think differently. We have to think bigger and bolder than just small pilots, but we actually do need to look at doing something at a national scale. We're small enough that we should be able to do that, but it's going to take everyone. We've seen it from Ronan's slide. Ireland has got such a rich ecosystem, the med tech industry, the pharma industry, the amount of health tech startups that are here. The ingredients are all here. We just need to work together and we can make it happen.
Great. Well, great to see you all, and thank you so much, all of you, for taking part in our panel discussion today.